Please listen carefully.
Hello, and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out GasGasGas.uk. There's show notes there, there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Well, good morning everyone. We have done a whole chapter on opioid pharmacology for the FRCA primary exam. We did oxycodone, tramadol, methadone, remifentanil, as well as the more particular and core drugs, morphine, diamorphine, fentanyl, and alfentanil. And we touched base with their use neuraxially, comparing and contrasting them, and dabbed in with Minto model stuff for remifentanil. However, you've heard all this stuff, you've seen it at work, and you've given it to patients, I'm sure, but now it's time to check your knowledge, and we're going to do so with yet another quiz. Now, we're doing a quiz because actually when I did the local anaesthetics quiz, I was surprised by how many people listened to it. But I suppose if you sat in your car, maybe answering some questions and immediately identifying if you are right or wrong is actually quite useful, and we're going to do that again, but this time on opioids. If you like what you hear, maybe think about firing off a donation to help support the show and keep it running, and help keep my wife off my back for spending far too much time doing this. But it is a little bit of fun as well, isn't it? So, we're going to do some sort of quick-fire, facty questions, and then some slightly longer format, here's a clinical vignette, what are your thoughts type questions. If you think anything is particularly awkward or particularly good, fire off an email. I know quite a lot of you have now. And let me know, because there's going to be one of these on hypnotics coming, and then once I get in amongst volatiles, which I'm currently planning, I'm trying to be a bit better and plan further ahead, we're always going to do a quiz, because you can always come back to it and do it again and again whilst you're stuck in traffic on the M1, M6, that ring road round London, M25. We'll cue the slightly saucy jazz. Question 1. Describe the mechanism by which opioid receptor agonists produce analgesia at the cellular level. Things I want you to tell me: where the receptor is, what it is, how it works. Go. Opiate receptors are found throughout the body. The particular areas we are interested in focus on the central nervous system, chiefly in the para-aqueductal grey matter of the brain, as well as the substantia gelatinosa brachioid lamina 2 in the dorsal horn of the spinal cord. You may also find some receptors in the peripheral nervous system. It works through agonism of G-protein coupled receptors. These are GI subunit G-protein coupled receptors. Upon agonism of these G-protein coupled receptors, which remember are serpiginous 7 transmembrane domain, inhibit activity of intracellular adenyl cyclase. This leads to reduced cyclic AMP in the cell, which leads to increased potassium efflux from the nerve, a reduction of calcium influx, and a net change in the polarity of the cell, making it harder for it to depolarize. Next question. Compare and contrast the different opioid receptors found in the human body. MOP, COP, DOP, and NOP. MOP being mu opioid peptide receptor, kappa for K, delta for D, and nociceptin for N. Mu opioid receptors exert analgesic, respiratory depression, euphoric, and constipating effects, as well as bradycardia. COP, kappa receptors mediate analgesia, sedation, and meiosis. DOP, delta opioid receptors, mood modulation, and nociceptin, which is a newer receptor. If agonized minimally, you end up with hyperalgesia, and when agonized potently, analgesia. What pharmacokinetic features of diamorphine lead to its clinical effect being so potent and rapid? Diamorphine is a prodrug. So diamorphine, diacetylmorphine, is exceptionally lipophilic. So it is very good at crossing membranes and getting to point of action. However, it itself is not very much of a mu agonist, but it undergoes esterase breakdown by pseudocholinesterase and RBC esterases, cleaving an acetyl group, creating 6-O-acetylmorphine, which is its active metabolite that is a mu-opioid agonist. This is further metabolized in the liver to morphine, and then you will see hepatic glucuronidation to morphine 3-glucuronide and morphine 6-glucuronide, morphine 6 being quite a potent metabolite in itself. The stark lipid solubility of diacetylmorphine is why you get such a rapid onset of effect, and therefore the associated euphoria because of that high peak plasma concentration getting into the CNS. What is pKa and why is it relevant in opioid analgesics? pKa corresponds to the pH at which the molecule is in a 50-50 state of ionized and unionized. For example, if an agent had a pKa of 8 and it was in a solution with a pH of 8, it would be 50-50 unionized. Why is this relevant with opioids? Well, unionized molecules membranes and can therefore get to where the opioid receptors are, whereas ionized molecules are unable to cross fatty membranes, of which there are legion in the human body. Therefore, a pKa which facilitates a high unionized fraction will lead to a more rapid onset of drug, although this isn't the only factor that influences drug onset, as lipid solubility is important as well. What's the difference in pKa between alfentanil and fentanyl and their comparative onset times? So the pKa of fentanyl is 8.4 and it is 9% unionized, whereas alfentanil has a pKa of 6.5, is 89% unionized. When comparing the onset times, alfentanil has a rapid onset time, perhaps a minute to 90 seconds, whereas fentanyl is 3 to 5 minutes. Considering morphine in this context, you would expect fentanyl to take much longer to exert an effect. Its lipid solubility is 600 times that of morphine, and this leads to the rapidity of onset of fentanyl comparatively. What is context-sensitive half-time, and can you compare the context-sensitive half-times of fentanyl and remifentanil, please? Context-sensitive half-time describes a situation where the half-life of a drug is directly influenced by the period over which it is infused. Some drugs with prolonged infusion times have a prolonged half-life. This is important to consider, particularly for patients on intensive care or when choosing a opioid of choice intraoperatively if you're choosing to infuse that opioid. Remifentanil is context insensitive, and this is because it is rapidly metabolized by a system that is virtually unsaturatable because it is broken down by esterases in the plasma, whereas fentanyl, reliant on hepatic clearance alongside its exceptional lipid solubility, will accumulate as a reservoir in the patient that is dependent on transferring from fat stores to the liver via the plasma to clear. This plasma phase can exert an effect. You have a 75-year-old patient with CKD4. Their EGFR is 20 to 25, and they've been receiving regular morphine on the orthopaedic ward, having had a femoral shaft fracture, unfortunately, 3 days ago. However, they are now drowsy with a respiratory rate of 6, and they've just been receiving their 10 of Orawarf as and when required. Explain the pharmacokinetic basis for why this has occurred. Morphine has active metabolites, and those active metabolites are not cleared so effectively when there is renal impairment. So morphine is metabolized in the liver into chiefly morphine 3 glucuronide and then somewhat into morphine 6 glucuronide. The ratio could be described as about 90% M3G, 10% M6G. M6G, morphine 6 glucuronide, is 13 times more potent than morphine, and it is reliant entirely on renal excretion. Therefore, in patients with renal impairment, it has a prolonged clearance and can accumulate. It is a potent agent and causes sedation and respiratory depression. So you'd expect early in his clinical course that the morphine was fine. However, later in his clinical course, he's accumulated this metabolite. It was a small fraction of the metabolite. However, now it's exerting a clinical effect. This patient requires naloxone and a change in their drug to an agent that is less reliant on renal excretion, for example, oxycodone. What is the pharmacokinetic basis of intrathecal morphine causing respiratory depression? Morphine is relatively lipid insoluble and fairly water soluble. This means that it actually tracks quite broadly in the CSF space, as opposed to more lipophilic agents, which quite rapidly bind to the fatty spinal cord. This diffusion of morphine throughout the CSF space leads to opioid effects on the respiratory centres of the brainstem. Classic peak for this is 6 hours post-operatively. Note here, guys, if you can tell me the intrathecal dose of morphine, that's extra points. You're right, 100 to 200 micrograms intrathecally. You can give more, but you're going to have more respiratory depression and probably an itchier patient. You are the lucky holder of the obstetric anaesthetic on call bleep, and you are called to labour ward triage, where a 28-year-old woman has attended with severe preeclampsia and, unfortunately, placental abruption. CTG is very concerning and a GA section is indicated. The patient's blood pressure is 185 over 110. The obstetric reg has already arranged magnesium, which is going in right this very second, and they are transferring the patient to theatre. Presume that you've assessed the patient for an anaesthetic, and you're going to do a GA. Tons the pressor response to laryngoscopy in this situation. Naturally, guys, this is an opioids quiz, so I'm expecting you to say some sort of opiate. Alfentanil is classically the one to choose, and in quite a large dose, so 1,500 mics, 2,000 micrograms. Why do you want to do this? Well, if their blood pressure's roaring, and then you tip it up even higher, because remember, they're quite labile with their blood pressure in this situation, you might cause an intracranial hemorrhage, and that is bad news. So a whacking dose of alpha. Tell the paediatricians that the baby might come out. Actually, this does mean that the baby might get some alfentanil and be quite dozy and minimally breathy when they come out, and you need to tell the paediatricians this. Other things you could do, but it's very much less familiar, is you could use a dose of rapid-acting antihypertensive like esmolol. Remember, labetalol takes like 5 to 10 minutes to really get going. You could give them a dose of magnesium as you'd get them off to sleep, although they've already had some in this situation. Other agents like remifentanil as a bolus at induction, or fentanyl, but you'll have to wait. Remi would be a quicker option to use and would offset faster, which might be good for the BAB as well, actually. Noting that we are less familiar with remifentanil dosing, and it can cause mischief like bradycardia, which you might not want. So use video laryngoscopy with as little lift as you can, and use a bougie and pass that tube gently. So you've decided that remifentanil as a bolus is something that you're interested in developing the skills to use. You, with your consultant, have given a patient a 3 mic per kilo remifentanil bolus at induction, and suddenly you cannot ventilate them. What has happened? Why has it happened? What are you going to do about it? Remifentanil, along with any other opiates in sufficiently large doses, but remifentanil or perhaps fentanyl, wooden chest phenomenon. Wooden chest phenomenon, aka chest wall rigidity, thought to be mediated by mu opioid receptor agonism in GABAergic interneurons in the spinal cord, i.e. inhibitory interneurons. This leads to disinhibition of motor neurons and this stiffness that we then see. It can affect the chest wall, the abdomen, and the jaw. The treatment is to paralyze the patient. Centrally mediated high tone will not persist when you block the neuromuscular junction at the nerve-muscle interface. You are called to recovery for a gentleman who is in gibbering agony. You discover that he's had a laparoscopic cholecystectomy, but he had been on the waiting list for a really long time. It was surgically challenging, terribly stuck down, and you notice he has a history of chronic pain. He's on gabapentin and amitriptyline for his back, but also his gallbladder pain. You note he's had a Viva anaesthetic, and you spot that the remifentanil was at an effect site of 9 for quite a degree of the operation because he was so hypertensive during. He's probably an untreated hypertensive and perhaps an alcoholic. He had 10 milligrams of morphine at the end of surgery, and he's had a further 100 mics of fentanyl in recovery. What's going on? This gentleman perhaps has remifentanil-mediated hyperalgesia. This means he's exceptionally sensitive to pain stimulus at this point in time, and this would fit with his high remi dose and his background of chronic pain requiring this high remi dose. How might I deal with this? So, multimodal analgesia. I need to review whether or not he's had paracetamol, whether he can have NSAIDs, and consider adding these in or reaching for some intravenous ketamine for this patient. So, as an aside, when answering this sort of question, be thinking about why is this patient in so much pain? Is there a surgical complication developing? Is it their bladder full of urine and they're failing to articulate that? So add in magnesium and clonidine or dexmedetomidine to try and help this patient's pain. I suppose a niche option might be a lidocaine infusion, but again, that's small fry. You're on ITU and you're doing your morning reviews, lucky you, and you're assessing a 37-year-old man with acute pancreatitis. It's day 3 and he's becoming agitated, tremulous. His heart rate's 120. His temperature is 38.9. And when you go to examine him, he's quite twitchy and you think he might be hyperreflexic. He's on fluoxetine normally and he's on fentanyl sedation. What's the differential diagnosis here? Fentanyl and fluoxetine both have serotonergic activity. This additive combination may have led to a serotonin syndrome. However, important differentials here would be alcohol withdrawal, delirium, developing sepsis, neuroleptic malignant syndrome. Now, NMS would more classically occur with antipsychotic agents. I would like to check to make sure this patient hasn't had haloperidol. Sepsis, less likely with the neurological signs. Alcohol withdrawal, this is something we should explore. So here, folks, it's important to remember that some drugs have serotonin activity, even though we don't talk about it. Fentanyl, mild serotonin activity. Methadone, serotonin activity. So just be aware of that. It would be a banging diagnosis to make. You are doing a preoperative assessment on a patient who's having an inguinal hernia repair. You explore their past medical history and ask them if they're okay with paracetamol and non-steroidals, which is the one you're really more interested in. And the patient pipes up saying, "Oh, I'm fine with paracetamol and ibuprofen, but actually codeine never works for me, doctor. What are you going to do? Am I going to end up with some of that after my operation? My appendix done, they gave me codeine, and I was just in so much pain, and then someone prescribed me tramadol, and it just didn't work either. What are you going to do about it, folks?" Codeine and tramadol are both reliant on metabolism to their more active forms. The enzyme system is CYP2D6, and if this enzyme system is feckless and a bit useless, which in 10% of the population it is, codeine and tramadol won't exert very much of an effect at all. How would I overcome this in this patient? I would reach for Oromorph, and I would not use codeine or tramadol, and I'd explain to the patient my rationale for this. Feel free to take a break at this point. We have gone through quite a few things, and the next half of this podcast is going to be some quick fire. Facts, which we'll get through. What is the pKa of morphine, and what is its unionized fraction? Morphine has a pKa of 8 and it's 23% unionized at physiological pH. The pKa of fentanyl, and give me its unionized fraction. Fentanyl, pKa 8.4, 9% unionized. Right, and the pKa of alfentanil. The pKa of alfentanil is 6.5 and it is 89% unionized. Last but not least, what is the pKa of remifentanil? Remifentanil's pKa is 7.1 and it is 68% unionized. Now, from lowest pKa to highest pKa, rank those drugs for me. That is morphine, alfentanil, fentanyl, or remifentanil. Go! Alfentanil at 6.5, remifentanil at 7.1, morphine at pKa 8, fentanyl at pKa 8.4. Protein binding time! Ooh, exciting. How protein bound is morphine? Morphine is 20 to 40% protein bound. And what about fentanyl's protein binding, I say? Fentanyl is 81 to 94%, so very protein bound. Alfentanil's protein binding, again super duper high, 85 to 92%. And last but not least, what is the protein binding of remifentanil? Remifentanil is 70% protein bound. Now you know what I'm going to ask you next. What is, from least to most, the ranking of protein binding with morphine, fentanyl, alfentanil, and remifentanil? Morphine is the least protein bound of these at 20 to 40%, followed by remifentanil, 70% protein bound, and then fentanyl, 81 to 94% protein binding, and then alfentanil, 85 to 92% protein bounding, although alfentanil and fentanyl are very close. Volume of distribution time. I hope you're not getting bored. This does come up in the exam. I'm really sorry. So, what is morphine's volume of distribution? 3 to 4 litres per kilo for morphine. What is fentanyl's volume of distribution? 0.88 to 4.4 litres per kilo, guys. Remember, it is really lipid soluble and it's infusion dependent. What about alfentanil's volume of distribution? Alfentanil's volume of distribution of 0.4 to 1.1 litres per kilo, less than fentanyl. Remifentanil's volume of distribution. We know that it disappears very quickly, so it'd be quite hard to really truly measure this, but 0.1 litres per kilo for a single dose of Remi. Lowest volume of distribution to highest, go. Remifentanil at 0.1, alfentanil with its 0.4 to 1.1 litre range, followed by morphine 3 to 4 litres, and then fentanyl 4.4 litres. Metabolism fun times. How is morphine metabolized? Morphine is metabolized by the liver, undergoing glucuronidation into morphine 3 glucuronide and morphine 6 glucuronide. So what's special about morphine 6 glucuronide? It is 13 times more potent than morphine. It is renally cleared, and it accumulates in renal failure. How is diamorphine metabolized? Well, it is initially converted to 6-O-acetylmorphine by esterases, which is then subsequently converted to morphine, and then morphine 3 glucuronide and morphine 6 glucuronide. How is fentanyl metabolized? Again, liver metabolism for fentanyl, CYP3A4, N-demethylation to norfentanyl, and norfentanyl is inactive. And what about alfentanil? How is that metabolized? Alfentanil is metabolized by CYP3A4 and a few other cytochromes to noralfentanil N-dealkylation. How is remifentanil metabolized? Remifentanil is rapidly metabolized by plasma and tissue esterases into an inactive or almost entirely inactive molecule. Rank from fastest in onset to slowest in onset. Remifentanil, alfentanil, fentanyl, and morphine, all intravenously administered, of course. Alfentanil is likely the fastest here, quickly followed by remifentanil, fentanyl, and morphine. Quoted numbers here: 30 to 90 seconds for alfentanil, 1 to 2 minutes for remifentanil, 3 to 5 minutes for fentanyl, 15 minutes plus 15 to 30 for morphine intravenously. The patient is on 240 milligrams of codeine per day, every day. Convert this to oromorph. Codeine considered 1/10 the potency of morphine, so 240 milligrams of codeine would be the equivalent to 24 milligrams of oromorph. What is the relative potency of 100 micrograms of fentanyl against morphine? 100 mics of fentanyl is approximately equivalent to 10 milligrams of morphine. Therefore, 100 micrograms of fentanyl against 10,000 micrograms of morphine. So therefore it's 100 times the potency. Wow. What chemical class of opioids is morphine from? Morphine is a phenanthronine derivative, remembering that fentanyl is a phenylpiperidine alongside its alfentanil and remifentanil mates. Struth, that was a lot of questions, guys. There are always more questions. Literally any questions you can get your hands on are handy for this exam. There's loads of books, and then there's online question banks as well. Because it just goes on forever. I think being able to rank these drugs by simple core properties is something that is useful in the SBAs as well as may come up in the Viva when you're having a chat about opioids and comparing and contrasting, etc., etc. So I hope you've had a really joyful commute to work, or perhaps you're commuting back from work whilst doing this delightful stash of questions. A show note of sorts is going to appear for this episode with all these other questions that I've prepared that I clearly can't go into because I've just got carried away.